Morning, everybody. We're starting the heart. Yay. I'll do a tiny anatomy review. As you'll see, I cut all that stuff out. I used to do the whole lecture anatomy review, and I got to focus on my pathology. So you're going to have to do that on your own, because you're going to be lost if you don't understand anatomy. Then we're going to get into the congenital heart diseases. That's where we're going. Anatomy of the heart. We'll do a tiny, tiny bit. Now, I'm going to assume you know the basics. If you don't, go to YouTube and search Professor Doug's lecture page, Heart Anatomy Review, and this lecture will pop up. I would definitely go through that. You got boards coming up. You have to know this anyway, and you'll get much more out of this video and this whole series of lectures if you understand the heart anatomy. I assume you know terms like your ABC. These should be just like if I say, what is a cat? What is a dog? What is the superior vena cava? What is the inferior vena cava? Right and left atria, ventricles, the atrioventricular valves, aka which specifically are called tricuspid, and mitral valves. The brachiocephalic trunk, we learned that way back in first and second quarter. Sometimes it's also called the innominate artery. The semilunar valves are individually named the aortic and the pulmonic. We never say the right semilunar valve, the left semilunar valve in pathology. The pulmonary trunk, the right and left pulmonary arteries, taking deoxygenated blood away from the heart, which is weird because arteries usually have oxygenated blood. And then the right and left pulmonary veins. Remember, there's 4 of them, 2 coming back on each side. And yeah, absolutely make sure you know the flow of blood. And I think you should know this from the first lecture, but yeah, flow of blood. Here's the superior vena cava. Inferior vena cava is down here. And the blood goes into here. Remember, there was a foramen ovale during development where blood shot right through this hole into the left atrium. The left atrium is not over here, by the way. This is just a cartoon. The left atrium is right behind this. Like if I could draw the left atrium, it would be right about here, but it's more posteriorly. That's an important concept. Once you're born, those flaps come together and you have yourself the fossa ovalis, which we're going to get into today. Then the blood goes through the tricuspid valve into the right ventricle. Then it goes through the pulmonary valve, or the pulmonic valve, into this pipe. What's that one called? Pulmonary trunk. It splits into a right and left pulmonary artery, goes into the lungs, dumps its carbon dioxide, picks up oxygen, then it comes back in 2 pipes. Those are pulmonary veins into the left atrium, through we never call this the bicuspid valve. This is always called the mitral valve, very, very important, into the left ventricle. Systole occurs and shoots it out the left ventricle through the aortic valves, and this is the root of the aorta in red here. We've talked about that. Goes up the ascending aorta, which curves a little at the top. Once you hit this area, this is the aorta from here to here, and then descending aorta is right after that. Right? This has a special name. We'll look at that special name. This piece right here, sometimes given a special name. We'll look at that when the time comes. All right, so that fossa ovalis is really clinically important. So it's a very thin structure. If you remember it in Gross 2 lab, if you played with it, it's super thin. If you put a light in the left atrium, you can see the light from the right atrium. It's formed by, as I said, it was once the foramen ovale in the fetal heart. It's located in the interatrial septum, and normally is pressure closed at birth, and we'll expand on that. And normally by the age of 1, it's fused shut. So if you're a 6-month-old baby, it's not permanently closed yet. It's closed by the higher pressure in the left atrium compared to the right atrium. But it's working on sealing shut. It fibroses together. And by around the age of 1, it's permanently closed. And most, but not all people. Here's just the Foramen Ovale here is closed. Once it's closed, it becomes the Fossa ovalis. But in embryological times, the blood flows right into that and right through the left. Again, this cartoon, left atrium should be behind there. All right, we already went over the flow here, so this is a view we're going to look at time and time again. So this is a view of the heart, but from the right side, and you can see the inferior vena cava, superior vena cava, and you can see in this view how this is left ventricle here, or left atrium would be. I'm drawing it. It would be right back here. See, we can see some pulmonary veins coming into it. So right behind this little door is the left atrium. We're looking at the right atrium. The right atrium, this wall of the right lateral wall of the right atrium has been cut. And this part of the heart has been peeled back, and we can see all the stuff in here. But the key of the star of the show right now is the fossa ovalis. And the fossa ovalis is, again, intraatrial septum. It's very thin, and it has thicker tissue. This is much thicker, right? This is formed by septum primum and septum secundum. It's a double wall. This is only septum primum. This is just that first layer that came down. And then this is a flap. If I pushed into it right here, this would pop right open. But then this lip right here, this is called the limbus. And the connection between these two is it's welding together, it's fibrosing together. So this is all, it's like a little welder. I have pictures of a welder here. It's all fibrosing together because we don't want this to be open. Right now it's just held shut because the pressure on the left atrium behind it is pushing toward us, kind of out of the plane of the page, and it's holding it shut. And we'll see about, what is it, 20%, 25% of people, they never got welding here. So they have what's called a pro-patent foramen ovale. We'll get to that though, I'm jumping ahead. There's some other parts we'll also get to when the time comes, but you should know that there is a eustachian valve here, and it doesn't really, it's not a valve, it's not going to close the inferior vena cava, but when blood flows through here, it stops blood from going immediately into the tricuspid valve and tricuspid, the orifice here, and it basically funnels blood into the fossa ovale, or the fossa ovalis area, which, remember, was an open hole in embryologic days and fetal days. And so this eustachian valve, why do we even care about that? Because eustachian valve mounts, kind of morphs into this mountain range called the tendon of Tordaro. And at the tip of the end of the tendon of Tordaro is where the AV node is. And cardiac electrophysiologists use this as a landmark to come to where the AV node is. The triangle of Koch, we'll get to the triangle of Koch in a bit. You can see right here there's a tricuspid valve, one of the cusps of the tricuspid. Another cusp right here. One cusp right here. And yeah, those are all the parts. SA node would be up in this region. Alright, see, I did a little anatomy view. Yep. It's pressure closed, as I said, because the pressure in the left atrium is much higher, and so it just pushes that flap into the limbus, and it's held for the first year of life. And for about 20-25% of you, I forget the numbers at 20 or 25, and we'll find out here in a minute, but it's pressure closed, and some people can go their whole life. The problem comes if you develop pulmonary hypertension. Okay, I'll try to stay focused though. We'll get to that in a little bit. So it's pressure closed. Right, so here's a nice kind of a junior high heart here, but it kind of demonstrates this quite nicely. So we literally have a valve here. You could think of it as a gate, right? And this gate is held shut by the high pressure. What would happen if the pressure got higher over here than lower over here if that valve wasn't welded shut? It would pop open and you'd get a flow of blood from right to left, and we'll learn it's called a right to left shunt. We'll learn that is not a good thing to have. Body does not tolerate that condition well. So everything I said, within the first year of life, about 75% of humans have that valve welded together by this little welder who goes in a little mini submarine and goes through your bloodstream. And no, not really. It's just almost a little inflammatory reaction. We're not exactly sure why that 25% don't get welded, but they don't. Yeah, and that's these people would not have a problem. If these people developed hypertension, they're not going to have a problem because that they have a closed fossa ovalis is closed. But that other 25% can be in trouble if they develop pulmonary hypertension. Okay, there's just another picture of it. Okay, and normally it's welded again. I can draw my little welding stuff right here. Great. Oh, I guess I did it there. Right, there's just another picture. Okay, so now let's get to some stuff. That should kind of is review. Although you probably didn't know that. Some people, about 25% of people, don't get that welding. If you don't get welding there's about 25% of people in our class, couple of you in our little small class, have a limbus that is not welded to the valve of the fossa ovalis, and you have what's called a patent foramen ovale. You have to be careful. There's so much misinformation on Google on this. People don't understand this. Patent foramen ovale is no big deal as long as you don't have any pulmonary hypertension. If you have normal heart, it doesn't matter because it's always pressure sealed. There's a tiny, minute chance of risk for stroke in people with these, but it's really, really small. It's not worth even talking about. Now, pulmonary hypertension develops, then we have a problem. Yeah, so 25% of humans, it doesn't close. The valve and the limbus, they don't weld or they don't fibrose together. And that passageway remains patent, and that's the word where that word patent foramen ovale comes from. But patent doesn't mean that blood's flowing through it. It's a potentially open channel, and it all depends about how much pressure you have in your right atrium versus your left atrium. Right? So sometimes this is also called a probe patent foramen ovale. Probe patent foramen ovale because and when you're studying hearts in Gross 2 lab, if you can push a valve through a probe between the limbus and the valve, then it's the patient. We used to have a heart like that. You could just push the probe. It wasn't ripped or anything. You could just push the probe right through there. So that's a probe patent foramen ovale. Right? So limbus, valve, welded in this person. 25% of people, it's not welded, so you can stick a probe or a catheter right in there. So what? Well, it's no big deal with people with a normally functioning cardiovascular system. Heart and lung pressures are normal. It doesn't. You can live your whole life and not have any trouble with that at all. It won't leak blood from left to right. Why? Because that's the way that valve works. As long as it's pressure closed, you don't have a problem. Right? So there's a normal one. Again, high pressure over here. It's closing the valve. No blood is going to leak through there. Now, when does it become trouble? Patent foramen ovale becomes trouble when you develop pulmonary hypertension. And we've talked about pulmonary hypertension. We'll talk about it again because it's so important. In someone with pulmonary hypertension, the right atrial pressure will begin to approach the pressure of the left atria. And as the condition worsens, eventually the pressure in the right atria will be higher than the pressure in the left atria. When that occurs, that little limbus and valve will pop open because it's not welded. And now you have a shunting of blood from the right atria into the left atria. And the problem is, in the right atria, do we have oxygenated or deoxygenated blood? Deoxygenated blood. The body does not like deoxygenated blood mixed into fresh oxygenated blood. It doesn't mind if you lose oxygenated blood into the deoxygenated blood. That doesn't care about that, because the percent of oxygen in the blood is still strong, still the same. But it doesn't like mixing deoxygenated blood into oxygenated blood, because that drops the percentage of oxygen that's carried in the blood, and that'll cause the whole body to start to become hypoxic. And ischemia, the tissues will experience ischemia and decreased perfusion. Those are all words that mean the oxygen has been decreased. Okay? So if you do develop pulmonary hypertension and you have a PFO, which is a patent foramen ovale, that valve is going to pop open, and you're going to have a, quote, pathological right to left shunting of blood. And as I said, the body doesn't like that one bit. So here's a cartoon of this. So this patient, maybe they have COPD, maybe they have a failing heart. We've talked about all the different beaver dams that can occur. And if you get a beaver dam in the lungs, or if you get a beaver dam in the heart, the blood is going to back up. There'll be an upstream backup, and upstream leads right into the right ventricle and then right into the right atrium. And once the pressure is higher in the right atrium, as we can see in this diagram, we have blood pop that foramen ovale right open, limbus and the valve popped apart, and now we just we're tainting our pure oxygenated blood with all this deoxygenated blood. So instead of 99% oxygenation, now down here we're down to 85% oxygenation because of that mix, and the body does not like that at all, and you're going to get symptoms. Yeah, simple as that, really. All right, and just to, I don't know, I just threw this in here last night, just to, for you struggling with what is this beaver dam thing, or maybe this is going on YouTube. It is actually going on YouTube, because I give up on virtual classroom. Let's say you have COPD, and the microcirculation in this lung is all scarred up, and it's very difficult. That's a big area of inflammation and fibrosis of the lung tissue. So when you're pushing blood through the right side of the heart, because here's the right ventricle, right? The blood goes out, goes down the pulmonary artery, and it hits this. It's going to have trouble getting through that mess, all that fibrosis. And that's going to cause a backup. That's like a beaver dam. And a beaver dam, we know, downstream, you have decreased blood flow. Right? So the blood coming back here, which is going all the way over here to the left atria, the blood flow is going to be decreased there. So you're going to have a decrease in blood pressure. Your body will sense that and try to beat harder. And so the right heart will try to push harder through this, and it can't, it can do it for a while, but the right heart is not designed to do that. So what's going to happen to the right heart? Beside having way high pressures here, right? You're going to have super high pressure here. You're going to be losing blood into the left atrial blood, which is going to decrease oxygenation to blood that's already a little hypovolemic because of the beaver dam. but you're going to wreck this side of the heart, right? So you're going to have right heart failure because of this. See how that works? All because of this beaver dam. Now the beaver dam, we could move the beaver dam. Maybe there's a tumor right here. Okay, in one of the pulmonary veins. Same thing, beaver dam. Have to try to push through it. Maybe the beaver dam is just this whole left side of the heart. Maybe it's failing and it can't process blood, so you get a big backup of blood waiting to be processed through the heart. That's a beaver dam, right? So you guys should know that. You're going to get tested on that really soon on Tuesday, if my memory serves. So, all right, that's the deal. What are the causes of pulmonary hypertension? Well, any beaver dam downstream. So a failing heart, a failing left heart. Just a failing heart in general can't pump blood. If the mitral valve or aortic valve are stenosed, if this valve right here, there's the mitral valve, what if it's all filled up with calcium and it's stiff and it doesn't open? So when atrial systole occurs, you can't get through here. So it's a beaver dam right there. Same thing. What if this valve is super stiff and filled with calcium? The aortic valve. Beaver dam can't get blood through here. So both of these instances, the blood backs up this way and it backs up into the right ventricle and then the right atrium, and then you got super high pressure here, and then the blood squirts through that PFO. See how that works? All right. So what we'll talk about, this is a little more complicated. ASDs, atrial septal defects, and ventricular septal defects. I will actually talk about ASDs here. I think do we start those? I can't remember. We'll find out. Ventricular septal defects we'll talk about next week. But there's something called Eisenmenger syndrome that can occur. Eisenmenger syndrome will cause pulmonary hypertension. And we'll cover it again, but basically on these two conditions you get an overfilling of the right side of the heart. So too much blood is being jammed through the lungs, and with time that causes inflammation and scarring of the microcirculation and acts like a beaver dam in the lungs. And eventually the pressures will rise. It causes pulmonary hypertension. So Eisenmenger syndrome is pronounced once the pressure in the right side of the heart exceeds that of the left side of the heart. We talked about the endothelin gene. There's some research about, because people get pulmonary hypertension and they don't know why they have it. It's called idiopathic pulmonary hypertension. But one possible cause is a mutation in the endothelin gene, which is always on when it's not supposed to be on. This gene is supposed to be off. So some people with pulmonary hypertension do have an overexpression of endothelin. What's the dangers of a right to left shunt? Well, we said already, you're going to get a general hypoxia and cyanosis of the body. You could suffer an embolism too. You could suffer a paradoxical embolism. How does that work? Well, if you're unlucky enough to have pulmonary hypertension and leaking a little blood from right to left through your atria, through the PFO, what happens if you get a piece of thrombus that breaks loose? You have factor V Leiden and you're a clotter. You form venous blood clots, which I shouldn't say. You form venous thrombosis, but just to understand. And you break one of those pieces of thrombus loose. It's like a bomb flowing up toward the lungs. When it goes through the heart, if it happens to go close to the wall, and remember that eustachian valve is forcing the blood right into that PFO now. So that embolism, that little piece of thrombus, is shooting right toward the open foramen ovale, we can call it now, and it can go the semi-dangerous pulmonary clot, which is called an embolism, right? That's flowing through the blood, which would normally get stuck in the lungs and cause some trouble. If it gets into the left side of the heart, the arterial blood, now we're in big trouble, right? Let's go back to this picture. Because if you get a clot in here, Okay, here's the clot. It came up through here. I think I have a picture of this. I probably don't need to draw it. But if it goes here in the right atrium and it crosses over here, it's going to go, right? It's loose. So it could go in one of the coronary vessels and clog up, let's say, the right coronary artery and cause a massive heart attack. It could go up, let's say, here. It could go through here. Here's your left common carotid artery, right? And it could go into your internal carotid artery and go up in your noodle and cause a massive stroke up here, right? Maybe it's like Russian roulette, or it's like roulette, that wheel where you spin in that ball. Who knows where it's going to end up? It could end up anywhere. So these arterial embolisms are incredibly dangerous. All right. Yep, so that's a paradoxical embolism. Also, because blood is flowing through a place that's not really designed for blood to flow through, it doesn't flow through there smoothly. So maybe you had a dental procedure and you got a bunch of bacteria into your mouth. There's usually quite a bit of bleeding in some dental procedures. And you get bacteria in your blood. Some of the bacteria could actually stick to the PFO, to the rough edges around the PFO that didn't fail to fuse together, and it can grow there, and you can get a big lump of bacteria. That's called endocarditis, inflammation of the endocardium of the heart. And that big bug ball could break loose and cause an arterial embolism and cause trouble as well. Chronic migraines are associated with these. Right heart failure, kidney failure due to decreased perfusion. Okay. And remember, the right heart failure is really from the beaver dam that's causing that. General hypoxia, yeah, the body, we said already, doesn't tolerate deoxygenated blood being mixed with oxygenated blood, and that causes a general decrease of oxygen and a general body decreased perfusion. And you'll start to get a little blue looking, like this patient. Right? So, yep, you'll develop signs of pallor, remember that's whiteness, or cyanosis, which is blueness. And yeah, that's the story. Signs of hypoxia, well, beside cyanosis, if you don't have enough oxygen to your body going through all your body tissues, you wear out real easy. You try to walk up the hill or walk up the stairs, and you're gasping for breath. It's almost like you just ran a mile, but you didn't. That's because you just don't have enough oxygen to feed your tissues, and you put any additional strain on the muscles to the point they demand more oxygen. There's no more oxygen to give them, and so you have to speed up your heart. You get tachypnea as well as dyspnea. Syncope, yeah, if there's not enough blood to the brain, you can start getting dizzy. You might even faint. Tachycardia is going, tachypnea is going to try to compensate because you can try to speed up the whole system. If you don't have enough oxygen, you could try to speed up the transport, the unloading of CO2 and the uptake of O2. You could speed that up by speeding up your heart and speeding up your breathing rate. Confusion, you're not getting enough blood to your brain. Lethargy, you don't have enough oxygen, you're just going to feel tired and headache, and if it gets bad, you can go into a coma and die from this. What about the blood work findings in these patients with chronic hypoxia? Well, the body, if this goes on for a while, if there's not enough, if your tissue's just constantly not getting enough oxygen, your body's smart. The body will make more red blood cells. If you can make more red blood cells, then you have more troops carrying the oxygen, so that will try to offset the problem. So the making of these extra red blood cells is called erythropoiesis. Really, technically, this is secondary erythropoiesis because we know the cause of it. So it's secondary to this PFO. Or any right, and this goes to any right to left shunt, what we're talking about, not just a PFO, pulmonary hypertension. Any condition that causes a right to left shunting of blood will do this. So maybe your tissue's feeling a little better, you're feeling better because you're getting more oxygenation, but you have too many red blood cells. That's going to bump up your hematocrit, right? Hematocrit is a measure of the number of red blood cells compared to everything else. And that's going to make your blood too thick or too viscous. What's that going to do to your blood pressure? There goes your blood pressure. So now your blood pressure is going to start rising. And when you have too many red blood cells, there's a word for that. And it's called polycythemia. Polycythemia. Right? And if you haven't had this, you'll get this. I think Dr. Dumani will teach you this. But hematocrit is just you spin a tube and it pushes all the red blood cells down to the bottom. And normally there's normal ratios. You can tell this patient has polycythemia. They have too many red blood cells because of a pathological right to left shunt. Right? So it makes the blood really thick. It increases the chance for clotting. And it causes hypertension. It wears out the heart. The heart has to push all this stuff, this thick blood around. Heart has to work harder for this. Then anemia is just the opposite. You don't have enough. There's different types of anemia. So, all right. Paradoxical embolism. I kind of already talked about this, but let's do it again. So people with PFOs or any type of right to left shunt, any hole in your heart, even an atrial septal defect or ventricular septal defect, which is a flat-out hole in the atria or a hole in the interventricular septum. Anytime you have pulmonary hypertension, you're at risk for pushing a embolism from the right to the left, as we already talked about. And if you have a stroke and on CT they see an embolism stuck in your middle cerebral artery, and they checked, they did an ultrasound of your lower extremities, and they found you had DVTs and still have some DVTs, then that can be called a paradoxical embolism. That came from the right side, or that came from the venous side, and it got in to the arterial side at the heart. That's the paradox, because a venous embolism should end up in the lungs, right? It shouldn't be able to get into the arterial side because the veins go back to the heart, and then they end up in the lungs, and they go down to the microcirculation. You can't push anything through the microcirculation. A clot will be stuck somewhere along the journey. It can't get into the arterial side. But if they find you have deep vein thrombosis, and then you end up having a stroke or a heart attack, and they see that piece of thrombus, you're diagnosed with a paradoxical embolism. My father-in-law had one of these things, and they did some work on his heart, an ultrasound CT on his heart, and sure enough, he's got a patent foramen ovale, and he's got pulmonary hypertension. That's exactly what happened to him, and he's supposed to have that hole closed, and he doesn't understand it, and he doesn't want to do it, but it's another story. Yeah, so these are very dangerous, paradoxical embolisms. As I already said, they go into the heart, they'll go down the coronary artery, they get stuck, you got yourself a heart attack. They go up into the brain, stroke. They get stuck in the superior mesenteric artery, you have an intestinal infarct. And I could go on and on and on. And oh no, so here's a leg, and somebody was in a 14-hour plane ride, and he developed some clotting, some thrombus formed here, and a piece of the clot broke loose when he got out of the plane seat. And unfortunately, he's got COPD on top of that, so he has pulmonary hypertension, and the pressure is higher here in the right atria compared to the left, so we always have a flowing of blood like this. And here comes the embolism, and instead of going to the lungs, instead of going down here where it's supposed to go, it goes right across. And now he's got a huge piece of gunk, a bomb going through here, and this is called the embolism. That ends up in his brain, and he has a massive stroke. Got it? Yep. So we said this already. Embolism could get stuck in the coronary arteries, causes a heart attack. Cerebral arteries causes a stroke. Celiac trunk. Oh, remember that trunk? That would be terrible to get one stuck there, because that's a huge supply to the liver, to the stomach, and the spleen, you could get ischemia of all of those tissues. That's a terrible place for it to get stuck. Maybe it goes and gets stuck in the kidney. Maybe not enough to cause a complete beaver dam, but just enough to cheat the kidney out of blood flow, because it acts as a beaver dam in the renal artery. And therefore you might have hypertension from that, because the kidney, we know that'll turn on the R2A system. Splanchnic arteries causes an intestinal infarct. Paradoxical embolism versus stroke. Some kind of fun facts. So when someone has a stroke, they do a CT and an MRI, and they look for the cause of it. Maybe it's a bleed. Maybe it's a, I don't know. Yeah, maybe it's an aneurysm that's ruptured. Maybe it's an embolism that got stuck up there. But 30% of the time, they never figure out what it is. Oh, you had a stroke. We don't know what happened. That's almost a third of people. So that's called a cryptogenic stroke. Cryptogenic stroke means they don't know why it happened. And interestingly, if you look at those people who had a cryptogenic stroke, about 50% of them have a patent foramen ovale. And so, the research goes further. There's some studies that show, because you're worried about having another stroke, right? If you go in and repair that PFO, patent foramen ovale, it seems to statistically decrease the chances of having a second stroke. So they were getting paradoxical emboli causing the stroke, and they, for whatever reason, they just missed it on the CT and MRI. They didn't see it, or maybe it was dissolved, caused the stroke and then kind of dissolved afterwards. But yeah, so it's recommended to surgically, if you've had a stroke, to surgically close those PFOs. And that increases your chance of not having it again. Yep, we said this already. The right heart tries to push through the hypertension, and it wrecks the right heart. So you can get right heart failure. We already talked about that. Here's an x-ray. 65-year-old comes in, heavy smoker. He's got a history of COPD, let's say emphysema. He's got emphysema. What are the two types of COPD, by the way? COPD is a double. You can have two things. That's either emphysema or chronic bronchitis. Let's say these lungs don't look emphysemic. Let's say he's got chronic bronchitis, which sometimes you can't see as well. But yeah, so he also has a history. His father had a hole in his heart. So you assume it's either a PFO or a Atrial Septal Defect, or something's wrong up there. So if he's got COPD, you're worried that he's got get a PF, or he could get a paradoxical embolism. But you take an x-ray, and here's what you see. Here's a nice chest film, and you can see this is not right. I don't know if you've had enough. There's the aortic knob right here, which is the aortic arch. So it should go down like this, and it should come down like this. That should be normal. And I'm not the greatest drawer in the world. But see how it's bulging out here instead of here? That's not right. So this whole heart has rotated. This side of the heart has rotated this way. And so what we're seeing is actually the right atrium right here, which is rotated over. That gives it this appearance. And you get this. The DACBRs, Dr. Davis, they will take care of you on this. You think my class is hard. Wait till you get to that class. Some of those classes are really hard, which is good because you got to know your radiology. I mean, you kill somebody if you miss things on imaging. Okay, other findings of a right to left shunt. Yeah, what about some clinical? Let's get out your stethoscope. Make some use of that. So if you auscultate the heart, you could hear what's called a holosystolic murmur, which holosystolic means it goes through S1 and S2 sounds. And this is best heard in the lower left sternal border, and you'll hear a whooshing murmur. It'll sound like an aneurysm, almost like a whoosh, instead of lub-dub, 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 whoosh-dub, whoosh-dub, whoosh-dub. That's a holosystolic murmur of the blood going across the ASD or the PFO. Okay. You can also, if you can auscultate it, you can put your finger, put your metacarpal phalangeal joints there, which are good at feeling vibration, and you could possibly detect a thrill, which is like a cat purring, again at the left lower sternal border. You could do blood work, and you could find erythrocytosis. Hematocrit will be raised. I could have added that in there as well. And maybe even a step further, so you can palpate. So not only can you auscultate a whole systolic murmur and palpate a cat purring, a systolic thrill, maybe you could look with your eyes and you could even see a heave. You can see the left lower sternal border heaving during systole. And those are all signs that blood is pathologically going from the right to the left. You can look at their nails, and they might have clubbing of the nails. Do you know what that is? Clubbing. No, it's not the 70s clubbing, which I used to do back in the day. This kind of clubbing. So we've talked about this, I think, haven't we? But if not, look at those fingernails. They look like little clubs. And it's painless. It's an enlargement of the distal phalanges. The pathophysiology is not completely understood. It's classically said that people with hypoxia, the farthest place away from the heart is the fingers and toes, and that's where the blood supply will be the lowest. And so, because this tissue is chronically exposed to blood flow that doesn't have a lot of oxygen in it, a lot of growth factors are released in the distal phalanges, and these growth factors start to make the nail bed expand and grow upward. And yeah, that's the classic theory, but we have a big problem with that, because people with Crohn's disease can also get clubbing of the nails, and that's got nothing to do with hypoxia. So there's some other thing going on. Maybe this is part of the explanation. This chronic subclinical cyanosis, but we don't understand it for sure. We should know. I always ask questions on this. You want to study something, you should study this. Lots of stars, even a circle here. But 80% of the time, the problem, if you have clubbing at starting, 80% of the time, it's a respiratory disease. Anybody with clubbing, and I've had probably half a dozen students over the years come through with this. And you got to get checked. You got to get a chest x-ray, and you got to do some testing to make sure you don't have a lung tumor. Kind of unusual in people your age. Cystic fibrosis, you would know. Bronchiectasia, you would have other lung symptoms. Lung abscess, pleural empyema, interstitial fibrosis. You would know all these, but this one you wouldn't, and that's why you get checked. 13% have a miscellaneous diagnosis as a cause of clubbing. That 13%, we have some categories. Congenital, this is what we're talking about now, right? There's our PFO. But any hole in the heart where you get a right to left shunting of blood, VSD, ASD, PDA, tetralogy of Fallot, we're going to cover all these. We're not going to get through them all in this lecture, but we're working our way that way. Liver cirrhosis is another cause of it. Subacute bacterial endocarditis. In fact, the guy who discovered this clubbing phenomenon, that's what he had. He had a bacterial infection of the heart, and he noticed his nails were getting really thick. And they made the diagnosis, and they treated him, and the nails decreased back in size. And then about 10 years later, the nails started getting thick again, and he went right in to get his heart tested. He already knew what it was, and sure enough, he had endocarditis. Chronic diarrhea can do it, infectious endocarditis. It's just kind of the same as subacute bacterial endocarditis, more of an acute thing. Crohn's disease. 7% of everybody is just idiopathic. All the students got tested, and they were okay that I know of. But 7% of the time there's a gene for it. So it doesn't always mean this is what students look like. Now if your parents and grandparents have this, it's probably just the gene. Still get the heart and lung exam though. Shamrock sign. So a quick way, you can do this right now. Using class, I have everybody put the backs of your nails together and look. Do this. Put the backs of your nails, the dorsal surface of your distal phalanges together, and there should be a little diamond. I'm going to do it right now. Yep, I got a little diamond between my nails, and that's great. That's normal. If you don't have the diamond right here, you got a little bit of clubbing going on, and some people they go on. I'm not going to test you, but there's an angle formed. Normally, the angle between the nail plate and the meaty part of the distal phalanx should be an angle of about 160 degrees. And mild clubbing is straight, and more severe clubbing is actually the angles diverse. We don't need to know that though. But for those of you who have to know everything, there you go. What about headaches and PFOs? Yeah, chronic migraine headaches have been associated with patent foramen ovales in people without pulmonary hypertension even. Especially the migraines that have an aura with them. And research for people, migraine headaches are really, really disabling. My wife has these, and she, luckily not too bad, a couple a year. But when she has them, she's down for a whole week. Some people are down for a day or two. She gets them so bad, she's sick and nauseated and throwing up, and yeah, it's a really big deal. So some people have, to fix that, they have tried closing the PFO, surgically close that hole, and it does statistically seem to decrease the prevalence or decrease the incidence of migraines. In other words, it decreases the amount of times you're going to get a migraine per year. So still a little controversial, but that's an area they're looking at. This is really, really interesting as well too. Is a PFO really a congenital heart disease? American Heart Association, on their website, they still have it listed under congenital heart diseases. Rubens and Robbins actually don't say either way. I mean, technically it's not, because to be a congenital heart disease, you have to be born with it. And everybody is born with a PFO. Right? It takes a year for the valve and the limbus to fuse together. So it's really not technically a congenital heart disease. So I don't know what to tell you on boards on that, because I'm not on that part of the test writing committee, but they have to be really careful with that, because it's technically not. It's really acquired, and you don't know the answer until about a year of age. You can make the diagnosis by injecting micro bubbles into the venous circulation, usually into the femoral vein. You can inject these little micro bubbles, and under ultrasound or under fluoroscopy, you can have the patient do a Valsalva's event and push down real hard as those bubbles pass through the heart, and that raises the pressure in the right side of the heart when you push down, and you can see the bubbles cross over. You got yourself a PFO. All right, let's switch gears. We're not going to finish this, but we're going to start talking about atrial septal defects. These are no doubt congenital heart, as a congenital heart condition. It doesn't take a year to show up. The baby is born with a hole in their heart. That's called the atrial septal defect. They're born with a hole in their atrial septum. If they have a hole in their ventricular septum, they have a ventricular septal defect. Which way is the blood going to flow? Right to left, or right to left, or left to right? Well, the left side of the heart, way higher pressure, so you're going to have a it's not normal, but you're not going to have cyanosis from this. You're going to develop a left to right shunt of blood, because the left heart has higher pressures. But the trouble is, it can wreck your lungs. Let's go into this. So atrial septal defects, definitely congenital heart disease. It's also, sometimes you could say it's a member of the cyanotic heart diseases. Could be born, you're born with this. The word cyanotic heart disease means it can eventually cause a mixed, it can eventually lead to a pathological right to left shunt. And there goes your PO2, right? You drop the amount of oxygen in your blood and you start turning blue. That's where cyanotic comes from. There's other members of this family: tetralogy of Fallot, ventricular septal defect, patent ductus arteriosus. Some also include, as just a heart defect, that stenosis, the coarctation of the aorta. Remember we talked about that in lecture and lab, where you get a congenital narrowing of the descending aorta, usually right after the aortic arch. But that wouldn't be a cyanotic heart defect, because that's not going to cause cyanosis. All right, we'll get to each one of those. What's the epidemiology? So it's about 0.1% of the population is born with this. So it's much more common than Marfan syndrome, which is 0.01. There are a bunch of gene mutations. I took all those slides out, you'll be happy to know, a while ago, because we just don't have time to go into the weeds. But there are known gene mutations for these. If mom or dad has one of these, your chances are they're elevated that you'll have one as well. Females are more affected, 3 to 1, than males. And yeah, it's the cause of congenital heart disease in about 33%. So if you're going to have a congenital heart disease, a third of the time, it's going to be an ASD. What does it do? What is it, and what does it do? It's a hole. It's a real hole in the intraatrial septum, and that's, I assume you know the anatomy. You have to watch that video, which I said way back at the beginning. And at first it causes a left to right shunt. And everybody, I should add more stars here. Everybody gets this messed up because they think, oh, hole in the heart, pathological right to left shunt. No, it's not good. You got to think where the pressures are. At first, you're going to have a right to left shunt because the pressure is higher in the left side of the heart than the right. But depending on how big the hole is, it's not going to stay that way. You're going to wear out the lungs really, really quickly. And to the point they start getting inflamed, the microcirculation gets inflamed and even fibrosed, and you create a beaver dam, and the pressure it'll get harder and harder to push blood through the lungs as that process is occurring. And eventually the pressure will, in the right side of the heart, will exceed that of the left side, and then you'll have a pathological right to left shunt. These atrial septal defects can be all over the place. You can have them anywhere, a hole anywhere. This is all intraatrial septum. You can even, the most common place for the hole to be is actually in the valve of the fossa ovalis, because that's the thinnest. That's not considered a PFO though. Remember, PFO is this where the valve and the limb meet. It wasn't fused. It didn't. The welders didn't get there and weld it. So that's different. That's a PFO. This is a flat-out hole you're born with. That's a ASD. Got it? And yeah, so it starts out with a shunting of blood. You're losing oxygenated blood, no big deal, because the percent oxygen in this blood that's going to feed the body, it's the same. It's just a little reduced, but you can speed up your heart to compensate for the loss, the cardiac output loss. Right. Atrial septal defects. Let's see. I always ask this question. So this is the most common congenital heart defect in adults. Why in adults? I'll tell you right now, a ventricular septal defect is the most common congenital heart defect in children. Why is that? Does anybody know the answer to that? Well, what about pressures in the atria compared to pressures in the ventricles? Atrial pressure is higher or lower? They're higher. No, they're not higher. Atrial pressures are low. It's not. It's a wimpy little structure. Yeah, so the transfer of left to right blood into the lungs, it's going to take a long time to wreck the lungs because you're not getting a huge extra volume in the right side of the heart. But what if you have a hole in the ventricles? Under high pressure, you're going to get a lot more extra blood going into the right ventricle and then going through the lungs. So basically the lungs are going to get wrecked a lot faster with a ventricular septal defect compared to an atrial septal defect. And when the lungs get wrecked, it causes pulmonary hypertension, and so the Eisenmenger syndrome that we talked about will develop much more rapidly in a VSD. And that once Eisenmenger syndrome occurs, that means you're getting a pathological right to left shunting of blood, and the kid is going to become symptomatic. They're going to be blue and have all those symptoms of cyanosis. It's going to the Eisenmenger syndrome, the process of causing pulmonary hypertension is going to be much quicker in a ventricular septal defect compared to an atrial septal defect. Got it? Play that back if you don't get that. Okay, everything I said. Why doesn't it show up in children? Atrial pressures are low compared to the ventricles. So the right heart doesn't get a whole ton of extra blood, so it takes a long time for Eisenmenger syndrome to occur. Right? Extra blood, so what? Well, there's the microcirculation again. This gets damaged, right? If you have a ton of blood going through here, it causes increased interstitial swelling, and you can get growth factors, can cause an inflammation, and growth factors come in and it starts scarring this all up, and it gets hard to push blood through the heart because of that, and that causes pulmonary hypertension. Kind of already talked about all that. All right, yep, so everything we've already talked about. The damaged lungs are now a beaver dam. It's harder for the right heart to push blood through that beaver dam, and that raises the pressure on the right side of the heart. That will cause a pathological right to left shunting of blood. Right, everything I've already said, and they'll start getting symptoms of, if you get right to left shunting of blood, remember we said the body hates that because it's taking away that full oxygen content of the oxygenated blood. It's mixing it with deoxygenated blood. Right, so there's the ASD. Eisenmenger syndrome has occurred. I could put this picture on the test and say, true or false, Eisenmenger syndrome has occurred in this patient. Yeah, has to be, right, because you got blood flowing from the right to the left. And is this patient going to be symptomatic? Yeah, they're going to be symptomatic. They're going to have hypoxia symptoms. All right. Yep, we've already said all this. You can read through this. The right heart gets worn out, and I've said this a couple times now. And reverse shunting has a name. We've already talked about this again, but here it is again. Once the pressure is higher in the right side of the heart than the left side of the heart, you get a pathological right to left flow of blood. They don't say flow usually, they say shunting of blood. And once that occurs, you have Eisenmenger syndrome. Hypoxia begins. And yep, we've covered all this. We said the body losing oxygenated blood into deoxygenated blood. That's not a big deal, but the body does not tolerate deoxygenated blood. Tainting good oxygenated blood causes hypoxia. Yep. There's a patient who died. You can see there's a PFO. Right, that's drooping the valve. This should be welded, and this valve is drooping right down. PFO, but we can see there's blood clotting here. They have ASDs all over the place. There's one there. There's one there. There's one there. There's a big one right here. Was this the one who died doing, I think this is a young person who died hot day football practice, doing sprints in the hot sun. Yep. All right, that's enough for your brains. See y'all later.